Hello.
Well, good morning, Dr. Rosensweet.
Good morning, Carolyn.
See you. Happy day.
We might have an echo. Let's see.
What do you think?
Let's keep going and I'll see.
Okay, it usually seems to go away because nothing else is on.
No, it sounds good. Yeah.
Okay, well, you sound good. And you look good. Glad to see it. Happy day, as I said, and welcome to everybody who's going to be coming up. And yeah, we have some good questions as we always do, and so let's get to it. Yeah.
Yeah.
Okay. Number one, Dr. Rosensweet, I am terrified to take hormones and only want to take them for the shortest amount of time possible. My fear is that I'm going to disrupt my body's natural hormone making abilities. And then when I stop taking the hormones, I'm going to go into a terrible withdrawal. I am menopausal. And again, as I said, I'm terrified and I'm confused.
Fabulous.
I thought you might like that one.
Let's deal with the word terror.
Yeah.
The Chinese started, the first recorded people treating women and men, women in menopause, men in andropause, the elite, the politically elite, about 1,000 years ago. And about 75 years ago, treatment of American women and worldwide women with hormones became so prevalent. In fact, by 2002, 40% of American women were being treated with hormones in menopause, 40% of women in menopause. They're being treated with Premarin and Prempro primarily, pregnant mare urine-derived estrogens, and also pregnant Premarin combined with a progestin molecule, challenging molecule, in the 18 million women, 40% of those in menopause in the United States. And there wasn't any controversy because, my God, when a woman loses her hormones, it's extremely consequential. Hormones are the most potent biochemicals in our body. And, you know, back in the day, as you and I remember from when we were roaming the tundra, or
never forget those days.
could have been in the Middle East, whatever it was, there was no menopause. There was no andropause. Men didn't lose their erection and their muscles and their drive and their motivation and their mood and their muscles. Did I say muscles? I want to be sure I said muscles, because it leads to canes, walkers, and wheelchairs when you lose your muscles. Men didn't lose their erection because they didn't live that long. It was very uncommon for people to live beyond midlife. It occurred, but it wasn't that common. And then with hygiene and agriculture, nutrition, we started living longer and longer.
Doctor.
And yet we are set up to stop reproducing. So the ovarian hormones and the testicular hormones, although they peak when we're 20 and they gradually decline, they fall off of a cliff in midlife. Well, these hormones are very powerful, like I was saying, and they're responsible for so many functions. For example, for a woman to maintain her bones, she needs her estrogen. For a woman to maintain her arteries, she needs her estrogens. I'm not even talking about hot flashes. For most women to be able to sleep, they need to have their progesterone and their estrogen. Their mood, their libido. For a woman to have her vagina, she will lose vaginal abilities, and intercourse will become painful, if not impossible, and she'll get subject to recurrent bladder infections if she does not sustain her estrogen. And the list goes on and on and on. And, you know, everyone can download a free PDF copy of the book in which I go into great detail, Happy, Healthy Hormones. You can download it from Ins and Outs of Menopause. Carolyn's made it available. The list is very long. Why is the list so long and so profound? Because these hormones are so powerful. Dr. Berkson, who's a frequent flyer, and she and I communicate frequently. She and I were having a discussion once, and we were just trying to estimate what would happen to American healthcare if hormones were restoration were universal. Like, what would happen to nursing homes and assisted living facilities? So many women and men are in nursing homes and assisted living facility because they've lost their ability to stand and walk. How'd that happen? They lost their testosterone. Women need testosterone as much as we need air, almost. Not that much, but we need it. And women need testosterone and men need testosterone. Just ask the millions and millions and millions of American men who are taking Viagra. Why are they taking Viagra? It's a substitute for their loss of testosterone. You want an erection? You got to have testosterone. And testosterone is declining in men in their 30s and 40s these days.
Well,
so the nursing homes are full primarily because of lack of ovarian hormones. Because women can no longer walk with stability. They go from canes to walkers, and then that transition to wheelchairs. They lose their levator ani muscle, because that's a muscle too. That holds up your bladder and your uterus. And when you lose that and you have vaginal atrophy, you get into adult diapers. And this is these are the two main reasons, not to mention cognitive loss, that women wind up in assisted living facilities and nursing homes. And who gets to know that? Do 40-year-old women consider that? No. And did I consider anything when I was 50? No. My health was sterling. I didn't think of health. I just thought of what other things that I had to do in my life.
No, of course, understood. I just wanted to say you're frozen, by the way.
Oh, no kidding. Gee whiz. Sorry to hear that. I may have to reboot. Let's see if I come back online. Can you hear me?
I can hear you.
Yeah, so let's see if I have to come back. If I may have to restart my whole thing here.
Yes.
The link will work, Carolyn.
Okay.
Do tell me if I unfreeze. So long as you can hear me, I'm going to keep talking, and I'm not going to reboot.
Yeah, we can hear you.
Why am I going into all this? Because the consequences of no hormones are just so profound. Not to mention arterial sclerosis. Half the women on the planet die of some complication of arterial sclerosis, heart attack and stroke. Why does all that happen? Primarily because of low hormones. That's why 18 million women in 2002 were on hormones. 40% of American women were on hormones in menopause. And then out comes this study called the Women's Health Initiative. And this all began with the word that the questioner said, the word she used, terror. Why in the world would a woman feel terror about hormones? It's because of this study. And the study was false. It never should have been published. It never should have been halted. Because one of the things that was learned by 2002 is women who are on Premarin alone, this is horse urine-derived estrogens, 50% of which no woman has ever seen. These women had a 0.79 relative risk for breast cancer. One is there's no risk, there's no extra risk, and there's no extra protection. They had a 0.79. That means women who were treated with Premarin in menopause were at less risk for breast cancer than women who were untreated. The relative risk for Prempro at that time was 1.26. There were so many problems in the Women's Health Initiative study. I don't even know, for the most expensive study that had ever been undertaken up to that time, why they made so many errors. They was obviously not dealing with experts. That's quite a claim.
It's
I'm a medical doctor. I'm making that claim that whoever dreamed up that study was just shot themselves in the foot because their study design was so faulted in many ways. But what they stated in that study was the relative risk for Prempro was 1.26, and they stated it was not statistically significant. What's not statistically significant means in menopause and in science and in medicine is it is not worthy to report. It's non-significant. It doesn't count. It's junk. But the press got a hold of that, and it was primarily because of one of the committee members of that study committee, who he already published it, and many on the committee objected because they saw that. It was too late. Cat was out of the bag. Terror spread to American women, women worldwide, and American healthcare providers. Terror. And that's where that woman's terror came from. Now, she didn't follow what I followed. I looked up I was concerned, but I saw the statistically insignificant. Then I looked into the European literature and saw that there was plenty of evidence that hormones were beneficial. I continued to treat. By 2006, that original study committee published that the relative risk of Prempro went to 1.0, i.e. no increased risk. But who heard of that? Or who heard in 2017 when that exact same Women's Health Initiative Study Committee reported in the original Journal of the American Medical Association, that after 18 years of follow-up, there was no increased risk of breast cancer, heart attack, and stroke. Did that reverse the terror? No. Very, very few women and very, very few healthcare providers have heard of that retraction.
Right.
The fear goes on. Thus, we get a question this week of I'm terrified around hormones. Terror.
Well, right. And then also saying, I only want to take them for the shortest amount of time possible.
Now, where did that come from? You only want to take them for the shortest amount of time possible. Who invented that strategy? Well, that was a prevailing strategy because millions of women went off hormones, went down to the very low millions, 18 million to the low 1 or 2 million women kept doing their hormones. Well, what happened to the 16 million or whatever that number was who went off? Big trouble. Big trouble because of all those things that happen to women in menopause without those hormones, or men in andropause without their testosterone. Notice men had their own fears being circulated, but they weren't as dramatic.
Yeah.
But go tell a man who's lost his erection that he does, and he's taking testosterone and it comes back, he doesn't need it.
Yeah,
why don't you tell him that?
Ain't gonna work.
This kind of crap did not happen to men. The crap happening to men was also wrong. Their increased fear of prostate cancer. The opposite is true. Men treated do better off, have healthier prostates than men who are untreated. So, because so many women were having disastrous, life-stopping events from going off their hormones, someone dreamed up this thing called, we'll take the smallest doses possible for the shortest amount of time. There was no science backing that up. It was just an invention. And because the women were desperate, that was the strategy. So I want to say number 2, as you brought up here, Carolyn, number 2 was, that is a bunch of garbage. And I'm going to give you my opinion. Take the proper amount, the optimal amount of hormones for your whole life. Don't stop. Or, again, to use the analogy, tell a man who's regained his muscle strength in his lower extremities and doesn't have to use a cane, is not heading towards a walker and wheelchair, and tell a man who lost his erection and started taking testosterone and his erection came back, tell him that he should take the smallest amount of testosterone for the shortest period of time.
Ain't gonna happen.
It ain't gonna happen. They're going to take it for every day of their life, as I do mine. Da-da.
Da-da. Yes, and as I do mine, and I will do mine, and forevermore. Thank you very much.
As long as we have access. Now,
yes, as long as we have access. Big one.
So the lowest dose for the shortest period of time is wrong. Now, I want to refer this particular woman, and every woman who has any concern to the science, because the science says women who are treated with hormones are at less risk for breast cancer, heart attack, and stroke than women who go untreated. Now, we're all at risk for hundreds and hundreds of diagnoses. Some of them are not pretty. Some of them are ugly. Some of them are life-ending. We're all at risk for cancer. As a man, I'm at increased risk for prostate cancer. And there's reasons why that's so. And women are at increased risk for breast cancer. And there's reasons why that is so. However, taking that into account that we can all pegger at any given moment here, which is Yiddish for disappear from the earth. I don't think that's the original translation, but it's one that I freely give. Pegger.
Pegger.
May Yiddish experts please jump in and correct me if I got this wrong. We could all pegger for millions of reasons. Women who are treated with hormones are at less risk for breast cancer, heart attack, and stroke than women who go untreated. Now, a book by a friend of your father's called Estrogen Matters by Avram Blooming, MD, is an oncologist who specialized in breast cancer, for God's sake. And his research and writing partner, Carol Tavris, who's a PhD, written a book called Estrogen Matters. Get that book, because you need to antidote that poison, and that book will do it.
It's a great book.
Not going to put you at zero risk. I'm grateful this morning. I got up, I'm walking and talking and thinking and having fun.
Yep, ditto.
So it's a miracle. But so many things in the statement, and I sympathize with you. I grew up treating women in menopause and having so much success doing so, and then getting that body blow in 2002, seeing it was incorrect, but watched the whole world of American women in menopause freeze, get terrified, drop their hormones, afraid if they take hormones, they're going to get breast cancer. The opposite is true. Women who are treated with hormones are less risk for breast cancer, heart attack, and stroke than women who are untreated. So, how do we antidote those thoughts in your mind, dear questioner, and in every other woman's mind, and every man's mind who's been frightened by a whole other group of lousy, false information?
I wish we could put a big billboard up all over the place that says exactly what you just said, so everybody.
So that's the best thing I could imagine, is that you read that book, Estrogen Matters. That those incorrect, damaging, damaged America. What did it do? Oh, lo and behold, at a very time when this planet Earth, and the United States in particular, but this whole planet, needs more feminine energy in the halls of family decisions, community decisions, political decisions, global decisions. It needs increased feminine energy. Bottom dropped out, because half the women in menopause are going to be so debilitated, they're going to lose so much, they're not going to be able to function at full throttle, and we need it. So the whole mission of the menopause method is to help retrieve and empower women to rise in the ability to make the decisions that this planet so desperately needs. We need feminine energy.
We have a really good video of you two up on Ins and Outs of Menopause talking about just that. It brought you to tears, and it's a very powerful statement you made and continue to make. And thank you.
So I'm always so happy to address this question as many times as I need to antidote the wrong, poisonous information planetary women and planetary healthcare providers received about hormones. The opposite of what's true. Well, these are challenging times. They've always been challenging. I mean, times are challenging. In 1942, when I was born, there's all kinds of threats. So, we're slowly evolving, hopefully. But meanwhile, there was other things in that question, but I don't think that questioner can move on until she gets it in her heart and in her bones and in her brain that, oh my God, I'm at less risk if I take hormones for the rest of my life at good dosages. Read Happy Healthy Hormones to see what we're describing there, what I call optimum hormonal treatment. That's where it all begins. She has to be able to antidote the incorrect information she has.
Right. And find the right physician, which is something we always say, to do the doctor shopping, which is so important because you hook up with that person who knows close to as much as you know, at least. And you hook up and you can do it and you can do it right and you can feel well and not terrified. The horrible way to feel.
Keep having sexual energy.
Oh my God, yeah.
Muscles. And don't have to go to canes, walkers, and wheelchair. And think clearly. Be vibrant. As one of my 79-year-old, I think she's now 80, patients, her goal for this year, I've been treating her for 20 years, is can she get 20 more yards out of her golf drive? Mm-hmm. Still having intercourse at the age of 80. You want that to be yourself? Yes, you do. Well, maybe not the intercourse part. You may or may not want that, but you do want to walk and you do want to think. And you don't want to wear adult diapers because I can tell you women do muscle up who have to do that. And you don't want to have to go into an assisted living facility and leave your home and family. God bless assisted living facility workers. Oh my God, they touch my heart. And nursing home workers. Oh my God, these are some of the people that are accepting some of the most significant, difficult work that there is on this planet.
Yes.
Bless their heart. I'm not trying to diminish this amazing miracle that we have where this care is available to many. Right. But at the same time, as a woman or as a man, most of you are not going to want to do that. You're going to want to stay walking, talking, thinking, and having your life at home with your family, with your community. You want that? Get hip to these hormones and get it right.
Absolutely.
Okay, I'm standing down from my soapbox. You forced me up there, Carolyn Shapiro. You forced me up to stand on a soapbox. It's all, you made me do it.
I did make you do it, and I will take full responsibility for doing so. How about that? Because I've been doing this a long time with you, and I just think it's fabulous. And thank you so much for always repeating that and never having a problem repeating that. It's very, very important for women to know, and we have a lot of new women that come up, and they don't know, hence the question. So I'll move on to question number 2, and that is, it says if a woman overdoses on progesterone, will her body convert that progesterone to estrogen? Many women, too, are saying that if one starts low and slowly with progesterone cream or oil, that will convert to cortisol, and that you have to start really high, 100 to 200 milligrams of progesterone, in order to avoid this. Are either of these true?
I'm just amazed at some of the ideas that pop up. In my experience, absolutely not.
Right.
No, zero. Erase it. For one thing, it's hard to overdose on progesterone. It's hard to overdose on most hormones, exception being cortisol. People who overdose on cortisol get high. That's very unusual. Almost every other hormone you name, it's very hard to overdose because you start getting symptoms of overdose. And as far as progesterone goes, progesterone is the great calmer. So if you get too much progesterone, you get too calm. Most common way that this occurs is a woman takes progesterone to assist her at bedtime to sleep. And if she overdoses, she's going to wake up groggy, like she's drunk, like she took an overdose of a sleeping pill the night before. And she ain't going to like it. And this is very common because one of the methods we use to maximize progesterone dose is to start low, have a woman take it at night, gradually increase it, and we have her gradually increase it until she wakes up the next morning and she is overdosed. She's groggy. And we always start off with 2 bottles of micronized progesterone when we give it orally. We get 1 bottle contains 25 milligram progesterone, and another bottle contains 50 milligram progesterone. We start at 50 for most women, not all. And we have them do that for a couple of nights. If that doesn't help them sleep, we increase to 75 milligrams. Do the math. You got 2 different size capsules there. And if that doesn't help them sleep, we increase it to 100 milligrams, and we keep climbing. Now, the highest we usually climb in my practice is 175 milligrams, but I know women who've made it to 200, 225. There's even a rare case of women making it to 300 before they wake up groggy. They don't like waking up groggy. It's hard to get moving.
Yeah.
The average in my practice that women finally land on when they're taking oral progesterone is between 75 and 125. But there are outliers. Some take more. There's so much sleep benefit for progesterone. So like I say, it's hard to overdose on progesterone as it is any other hormone because you usually get these overdose symptoms. Now, is there any harm from overdosing? Oh, by the way, so many women have osteoporosis that we like to address osteoporosis with some thoroughness. And some of the thoroughness that we do is we want to help the bones. And progesterone is the only substance that I know of that actively stimulates the osteoblasts, the cell that lay down new bone.
Right.
Progesterone is the only one that I know of that actually does that. And so there's women who have osteopenia or some bone loss. We like to maximize that progesterone, jack them up until they can take all that they can handle. Now, is there any downside to that? Well, we're testing women, so we know we're keeping an eye on the prize there. And yes, it is possible that too much progesterone, now, number one, it is not going to convert to estrogen, and it's very unlikely that it's going to convert to cortisol. Well, I think why people come to that conclusion that if you look at the biochemistry of it, and you can see the biochemistry roadmap in our book, well, theoretically, progesterone could convert to cortisol. In fact, in the adrenal gland, that's part of the pathway and how cortisol is developed. But it doesn't necessarily do that, practically speaking. Like I test women who are on very high doses of progesterone, 200 milligrams, commonly. Do I see elevated cortisol? No. In menopausal women, the thing you mostly see is a somewhat depressed cortisol because they've worn down their adrenal glands so much over time. So I never see what this theory would be for someone who had a theoretical glance at the biochemical roadmap where progesterone in the adrenal glands is converted to cortisol. Never see it. We're talking 20 years of 24-hour urine hormone testing, 23 years of doing it. Never see it. And I've seen plenty of women on very substantial doses of micronized progesterone. So theory, wrong. And I don't even know how progesterone could convert to estrogen by some obscure biochemical pathway. So don't worry about it. Now, interestingly enough, the principal occupant of estrogen receptor sites, because that's how hormones work. There's the hormone, and then there's the receptor site. And the hormone finds the receptor site, interacts. That's how this all begins, then comes out of the receptor site. Well, as far as estrogen receptor sites go, the most common occupant, the one that binds the tightest to estrogen receptor sites, is estrogen.
Yes.
However, progesterone also will bind estrogen receptor sites. So theoretically, there is a situation if the progesterone is way too high and the estrogen is too low, that it'll knock estrogen out of the receptor sites by a law called the law of chemical mass action. I'm not going to go into the details of that, but too much of something can make another hormone not work because it occupies the hormone's receptor sites. There's
Yeah.
that thing. There's another thing. This menstrual cycle, when you study it physiologically and biochemically, if you don't believe in a divine creator now, just study the menstrual cycle. The intricacy of it, the orchestration of it. It's mind-boggling. I can't even still get my mind around of how many different things happen. And here's a phenomenal thing. Progesterone facilitates the action of estrogen in estrogen receptor sites. That means for estrogen to act to its fullest capacity, it needs progesterone, which accounts for that some women, when they take progesterone, their estrogen starts working better and their hot flashes go away. There's some women who go into perimenopause, they're having some hot flashes. They take progesterone, the hot flashes go away. Hot flashes are a result of estrogen deficiency. And what's happening is the estrogen that they are producing, I mean, if they're in perimenopause, they're still menstruating, they still have a substantial amount of estrogen there, even though it's much less than when they were younger. If their estrogen starts working better, their hot flashes go away because the progesterone you gave them helped the estrogen in their bodies work better. Go figure. And some women get breast tenderness from taking progesterone, especially those who make the mistake of rubbing progesterone on their breasts. Now, it's not really a mistake. There's some body of knowledge that suggests women who have fibrocystic breast disease rub progesterone right on their breasts because progesterone balances estrogen in almost all instances. But there is this other situation where through that, and this is how I figured it out, or this is what I believe, I have no evidence of it, that if you rub progesterone on your breasts, you facilitate the function of estrogen in your breasts, which is another way how women get breast tenderness from taking progesterone. Moral of the story, there's a lot of moving parts with breast tenderness. And I, again, refer you to our book, Happy Healthy Hormones, because you want to get everything right. That's the thing. You want to get hormonal balance. You want to get correct levels of estrogen, progesterone. Don't forget testosterone. You're going to want that testosterone. Oh, yeah. And DHEA, as far as the ovarian hormones go, and thyroid as well. Progesterone even facilitates the function of thyroid hormone. In order to have maximum thyroid efficiency, a woman needs progesterone. How do you know that? Well, many of you have heard of the basal body temperature, in which a woman who wants to know if she's ovulating or not takes her temperature every morning. And if mid-cycle her temperature increases, that's living proof in most instances that she ovulated. Why does her temperature increase, for God's sake? Because a woman produces progesterone, a humongous amount, only if she ovulates. She has a minimal amount that's coming out of the adrenal gland if she doesn't ovulate. But if she ovulates, and when she ovulates, progesterone is produced by the cells that surrounded the egg that got ovulated. And if she ovulates, she puts out 100 times more progesterone than she does estrogen. Go figure. I think a woman's body likes progesterone 100 times more. Well, that progesterone facilitates metabolism. Metabolism is about taking the food you eat and the oxygen that you breathe, combining them, oxidizing it, and producing energy and heat. So people who have low metabolism have low body temperature. The main governor of metabolism is thyroid hormone. Progesterone itself doesn't raise the temperature, but progesterone facilitates the function of thyroid hormone.
Is the thyroid is the thyroid like the body's thermostat kind of?
Thyroid hormone plays into the facilitating of a process called metabolism, in which oxygen in the cells combines with the ultimate breakdown of the food you eat. Electrons are exchanged, and heat and energy are produced. The energy that we use to breathe, to talk, to think, to do everything. Heat is also produced. Thyroid is the principal facilitator of intracellular metabolism. Well, thyroid itself gets facilitated in the presence of adequate, healthy amounts of progesterone. That's why the temperature goes up, because progesterone facilitates the thyroid facilitates metabolism. You get increased heat and energy mid-cycle.
It's fascinating.
Holy mackerel. So
Yeah.
this is about progesterone and some of the multiple functions it has. And women, here's what you need to know. When you're in your 30s and you're losing your progesterone, because many women do, get progesterone. You can even get it over the counter. It's going to help you. Get it as early as you can. My book mentions this. Get into that progesterone as early as you can. Now, you're going to need to get into estrogen too, and eventually testosterone, no doubt about it. But a good way for you in your 30s, let's say that you're cruising along in your 30s, and all of a sudden you're starting to get increased PMS and breast tenderness. You are losing the balance of progesterone. You're no longer producing the exuberant amounts of progesterone that you used to. Get thee to progesterone. There's a lot of over-the-counter progesterone at that stage, not at all stages, that'll really help you. Get it and start using it, and read our book and start that process of going shopping for someone who really knows what they're doing about menopause, because the best thing you can do is start addressing these hormonal deficiencies as early and as expertly as you possibly can, because there ain't nothing like prolonging your life, your strength, your thinking, your heart, your arteries, your bones, than replenishing these hormones. Do it. Try and talk me out of taking my hormones. No way.
I wouldn't even dare try.
Thank you, Carolyn. Thank you for not trying to talk me out of my hormones.
It would never happen. And nobody will ever talk me out of taking my hormones.
Yeah.
I worked hard for them. Trust that. And not going to stop. Thank you for that, Dr. R. I'm going to get to this question. I've been promising this woman I will ask this for so long. She's asking, I was so excited to increase my estradiol and have been, I can't even read my own handwriting. I've been doing so for about a month because I couldn't tolerate a lot of progesterone. My estrogen got too high and I started to bleed for 9 days. So I cut back on the estradiol. And now again, I'm feeling like I'm losing my mind. It just seems there is no winning. Progesterone is making me horribly depressed. And low estrogen is making me feel like I'm falling off a cliff. It's making me bleed. And I just feel awful and I don't know what to do.
Yeah. I was chuckling with one of our premier healthcare providers who's been in our mastery program last week. And I was saying to her, how many typical and simple women do you deal with? And what percentage of your practice are simple and easy and respond just ideally when they go into menopause to hormone? And she said, she laughed and she was a little embarrassed because she thought maybe there was something not totally terrific about herself, although she's one of the most knowledgeable. Shout out to Mary Lee. Knowledgeable people that I've ever encountered about treating women in menopause. She said, I don't have anybody who's typical.
Right.
And it doesn't mean that's a problem. So I'm going to give you an analogy.
Okay.
And I've given this before. When I was in my late 20s, I was always sort of fascinated about maintaining my own automobiles. One of my favorites was my 1962 B18 Volvo. Loved it. Had to use stethoscopes to tune the dual carburetors. And I had a something Chevy Corvair van. And in 1968, I decided that, and it needed an engine rebuild. And I decided to rebuild it. And I got out an instruction manual, how to rebuild your Corvair engine. And by God, I did it. I rebuilt the whole engine. It took me months to do it. Had the whole engine apart. Down in there's not a single part that I didn't address. Anyone who's rebuilt an engine knows how many parts there are involved there. Put it back together, and by God, that engine started up. And it ran for 9,000 miles, at which point it froze.
Oops.
When an engine freezes, something was not done correctly. So when I wanted to rebuild my Volkswagen van engine, I decided to take it to a mechanic. This was in Santa Fe, who allowed me to watch the whole process. And it was staggering to me how many different steps of great rigor and carefulness he did than I had done. His knowledge base was triple, quadruple, 100 times greater than my own. There were so many things that I had left out. No wonder the thing froze. And that Volkswagen engine never stopped running. I eventually sold that van. So, and the human body is more complex. And as I tell those who join our mastery program, you're going to take our basic educational course. It's 12 hours, 84 quizzes. And that's the beginning. But you're not going to be good at this until your 50th patient. You're going to start getting a hang of it. At your 100th patient, you're going to go, wow, I'm starting to learn this stuff. At your 200th patient, you're going to go, wow, I'm sort of getting a handle on this. The amount, because there's so much individual variation woman to woman.
Absolutely, yeah.
And I know I dragged this story out quite a bit, but that's what's the going on here. There is so much individual variation, woman to woman. So I was probably 10 years into menopause, treating women as a specialty, where I started to go, wow, I'm getting this. And something now, to answer this woman's question, something is wrong with your program.
Yeah.
Because when a program is good, you feel good and you like it. And if you don't feel good, something's off. The amount of hormones that are being used, the actual hormones that are being used, you're using pure estradiol. I would never recommend that. I always recommend bias, but that's not the cause of your problem. The balance between the hormones, something is off. So what you need is what every woman needs, and this is what every woman in menopause needs. You need to go shopping until you find a professional, like my auto mechanic professional that I eventually found, rather than try to do it myself. And you have to go shopping these days. It's 2021. We're in very primitive times in every way. We also are in very resurgent times where millions of Americans and people worldwide are caring about their own personal healing. A little bit of a side there. But we're also in primitive times where you're going to have to go searching, shopping for a healthcare provider that, number one, you trust, you can communicate with, is going to be a partner with you, because you're going to need to partner with them, because you're going to have to go step by step to get your own individual thing locked in. And then also someone who's been trained, who's knowledgeable, and is using compounded bioidentical hormones. And if you really want to get down to it, find someone who's doing 24-hour urine hormone testing. If they're not, they just, in my non-humble opinion, they have not advanced far enough in the world of menopause. They haven't specialized in it enough to really know what's going on in your body. So you have to go shopping. And I wrote the book because I think it's also going to serve you, especially if you have to go shopping, to know something yourself, because these hormones are going in your body, and you can do some of the figuring it out when things don't work right, something's going wrong. Now, you mentioned if you're bleeding, you have too much estrogen. End of story. There's a rare woman who has endometrial cancer, so we pay attention to too much inappropriate bleeding, and transvaginal ultrasound will sort that out in most cases. You in a gynecologist. But the most common cause of increased bleeding is excessive estrogen. So you have too much estrogen. And yes, not balanced by progesterone is an issue. There is a certain, I'd say less than 1% of the women in 25 years that I've dealt with have this unusual sensitivity to progesterone. It's a bit of a shocker. And for one thing, any woman who's ever been pregnant or ever had a regular period is used to these really, really high levels of progesterone. Her body has experienced progesterone, so what's going on there? So there's a number of techniques that a provider can use to try and sort out that unusual progesterone sensitivity, including it starting at extremely low doses. We started at 1/100th of what we would ordinarily start at with our organic oils, progesterone topical. Sometimes it's the carrier, what the progesterone is in. Sometimes it's an allergy progesterone, and I refer you to Meridian Valley Clinic, Dr. Jonathan Wright's clinic in Washington. They have a test that they can check out what's going on with your progesterone. Why are you reacting funny to it? Meridian Valley Lab, Meridian Valley Clinic. It's in Tahoma, Washington. Dr. Jonathan Wright, a pioneer in menopausal medicine. He was one of the founders of compounded bioidentical hormones on this planet Earth.
Is it okay to put that up on the ins and outs?
Please do. Please do.
Okay. All right.
And he's a major world expert on this stuff.
Yeah, he's pretty amazing.
And yeah, so there's something off. And like Mary Lee and I chuckled about, there's no typical patient. So don't be shocked. Here's the other thing. It may take you a while to get yours balanced. I've had women that we've taken a year or two to get their proper balance. But once you do, it gets a lot easier. There's very little variation for the whole rest of your life. So you can be taking these hormones. You may have to tweak the dosages every so often. But once you get that balance, most women are home free. Now, in the menopause method, we check in with you annually. We test you annually. You want to confirm whatever your hormone levels are with a 24-hour urine hormone test. So to answer your question, something's off. It can seem confounding to you, but anyone who's trained in this has met up with all kinds of challenges the longer they've been doing this. And to them, we take it on like, oh, it's a puzzle. That's all. It's a detective search. Let's sort it out. Let's figure it out. We do so as a partnership with you. So
it's a beautiful thing too.
Yeah, take heart. There's nothing wrong with you. It's just like my Corvair van. That engine needed an expert to work on it. I just didn't know enough. I didn't have enough experience. I didn't know how to do the right thing. So think about the human body, for God's sake. Corvair van, human body, more complexity there in the human body.
Levon, you're welcome. Thank you, Dr. Rosensweet, so much for that. I think that we all kind of feel a little bit vulnerable, especially when we're not quite sure who we're working with or whatever. But we get there. We do. Next question. Why is it, please, that once I add in a low dose of estradiol to my progesterone, my joints get all wobbly and my muscles start to disappear? I'm totally confused with this. I thought that I was supposed to get stronger muscles.
Muscles, I'm going to give you the exact same answer I gave to the last woman. I'm going to give you the short version. Something's not right. There's a lot of moving parts. You're talking 4 hormones here, and getting the balance correct for your body, that's an art. And it's something that really requires due diligence, expertise, working out together, sometimes a month or 2 or 3 or 12 or 24. As we gradually, I mean, you've been declining in the hormones themselves in the balance for 20 years. You peaked out at your ovarian hormone output at the age of 20, and your body's been adjusting and readjusting to the low hormones. So it takes a while. So we're patient. That's why you guys are known to us guys as patients.
Yes.
And we're patient too. I'm a patient too. In a couple different ways. One, I'd better be patient in working with a hormonal imbalance because it takes patience. So it takes patience and patience on patient's part and my part, patience.
Lots of patience.
And the muscles are most related to the androgens, testosterone and DHEA. And do they go cattywonk? You betcha. There's not one single woman we've ever tested who 3 years beyond menopause has got anywhere near the adequate androgens to protect her muscles. You're going to lose her muscles. Take a look at the thighs of non-overweight women in their 70s and 80s. Take a look at the thighs. What happened to those thighs? They got thin. Take a look at the triceps. Got flabby. What happened there? You lost the muscle. You lose the muscle that holds up the bladder and the uterus. This is trouble in the pelvis. You lose the muscle because of the androgens. You lose other things because of the loss of estrogen and progesterone that are equally as valuable. So you don't want to lose anything. Now, these days, more than ever before, I'm seeing women in the perimenopause have low androgens.
Interesting.
Every woman in the perimenopause has low androgens. Some of them get an androgen elevation to compensate for the low estrogen because testosterone can be converted to estradiol. But this seems to be getting more and more rare. I can hardly any woman who's getting hair in her mustache area or chin in perimenopause, she's getting an androgen elevation that will not sustain. That's going to drop. But you got to be careful about giving those women androgens. You want to give them estrogen. So, yeah, same story. Your job is the same. You need to find an expert. That's it. Or you need to find someone who's really good, really trained. Contact the Menopause Method. Go to menopausemethod.com. We're accepting patients in about 10 states right now. These providers are in our mastery program. I'm mentoring them on every single case. Think about that. And they're going through a rigorous training program. And telemedicine. You have access to physicians in every single nook and cranny of your state that you live in. If they've got a license in your state, they can treat you. So it's getting easier and easier and easier to work with an expert. We're in 10 states or something.
Yeah, it's pretty incredible. It's pretty incredible.
So that's your job. Find an expert, because health is our core genetic propensity. And these things, they're challenging when we lose our hormones, but they're replenishable. And it's just an art and a science to do it. But your job is the same. Go find someone who's really put their time and energy into learning a whole bunch of stuff, has a whole bunch of tools, and knows how to do the adjustments, because that's what it's primarily about, prescribing and adjustments and testing. They'll get it right.
Right. And so it's okay to tweak this here and tweak that there and whatever. That's not
absolutely. It requires it. It's I don't know of a situation where we don't tweak it.
Right.
Like, we don't expect a woman that we're seeing for the first time who's pretty early on in menopause, we don't expect anything near balance till about the 3-month mark. It's very rare for us to even do the 24-hour urine hormone test before the 4-month or the 5-month mark, sometimes the 3-month mark, but that's pretty unusual. Why? Because they're not balanced yet, so why test them?
Yeah, right. And that's a question for another day. We have a few minutes left. I'm going to see if we can answer this last one. And I'm seeing everyone's questions, and I will get to you. I promise you eventually I will do. this question came up. Is there a hormone that would be out of balance if one is constantly hungry? I wake up at night hungry, and this cannot be normal.
It's not normal. Yeah, sorry.
It's fine. Yeah, okay, go ahead. It's not, I guess not. She says it's her worst menopausal symptom. What is going on? Do you think?
You're getting hypoglycemic most likely in the middle of the night. Your blood glucose is dropping. And that happens. And it's a story a little more than we have time. I'm going to give you the short version because I have a hard stop at 11 again. Why would your blood sugar drop? Well, there's lots of reasons why it can drop. Blood sugar is kept within an optimal range by a very, very rigorous system. Your brain does not like blood sugar droppage, and it will trigger this powerful scavenging mechanism called hunger if your blood sugar is dropping. So why would that drop? Well, the blood sugar is maintained in a lot of different ways. You don't necessarily have to eat food. That's a great way to do it. I mean, eating food is how you can restore your blood sugar. But if your blood sugar drops and you're not near food, your body can restore it by mobilizing glucose storage depots in your muscles, for example. Like there's something called glycogen, which is a complex carbohydrate that it can break down and raise your blood sugar back up. And your body knows how to do that. And if the glycogen runs out, because its stores are not infinite, it can start breaking down your fat, because fat can be converted into glucose. And if that doesn't work, it can break down your muscles. Uh-oh. You can break down your muscles, get them down to amino acids, and convert that to glucose. Gluconeogenesis, it's called. Read about this in our book, Happy, Healthy Hormones. We discuss this in the chapter on weight.
Great chapter.
We don't want to see that. We don't want repetitive. Now, I don't want to scare you. That's a last resort, and it's got to go on for a long period of time to have gluconeogenesis be the primary loss of your muscles. Usually what's happening, the protective mechanisms that can restore blood glucose when it starts dropping, called adrenaline and cortisol. Cortisol is part of a family of hormones called glucocorticoids. Why? Because one of their principal functions is they can get you blood sugar back to normal by just doing what they do.
Right.
But if you're low in cortisol or you're low in adrenaline or both, you've lost that protective mechanism and you tend to get hypoglycemic. So that's one cause of hypoglycemia. So some people have to restore their adrenal health. Some people just restoring their ovarian hormones will give the resources back to and help the adrenal glands and the cortisol bounce back. Some people have to take snacks in the middle of the night. Tapioca pudding is without the glucose is one of the principal ones. It's slow to digest, but it's not too hard to digest. And so look up hypoglycemia and some measures you can take to facilitate your own ability to keep your glucose normal until your adrenal glands recover, because usually your adrenal glands need to recover some oomph. And if you replenish your ovarian hormones, that'll give the adrenal glands a break and the cortisols will return to normal. We test them, we see them low all the time.
And we can all feel well and happy again.
Forever.
Sing a song.
Happy and in love and abundant forever. That's the name of where we're heading.
Exactly. Oh my God, my dear Dr. David Rosensweet, it's so good to see you. You were frozen to me the whole time, so I have no idea what you were doing. I see you in just one way, but everybody else saw you. So Happy day to all the women that came up. Thank you again, Dr. Rosensweet, always. And we will get to everybody. I don't even know what day it is again. I think, what is today Tuesday?
I'm going to sign off.
You're not answering my question.
I know. I am signing off because I'm past time. So I'm going to say goodbye to everybody.
See you later. We'll see you the day after tomorrow, I think.
Yeah. Bye-bye, everybody.
Bye, everybody. It's